This particular patient, we had careful planning. It was an anterior aesthetic zone case. In addition to the placement of the implants, I wanted to do some soft tissue augmentation at the same time. So we were positioning our implants, and today everybody has a good feel from the literature of what's ideal placement of an implant, tooth to tooth, implant to implant, implant to tooth, pontic to implant, and so on. And these are well documented in the literature. Some of the articles by Salama, Tarnow, and our other dental XP experts have given us this information, and you should download those articles. But in this particular patient, I wanted to be at least 2 millimeters from an adjacent tooth, and I wanted to be approximately 3 millimeters implant to implant. So my first positioning, I got 2.8 implant to implant and 2.9 implant to implant. So I was pretty close right away. I could do one of two things. I could slightly move the implant distally and get a little bit less next to the adjacent tooth, or I could change the size of the implant. To change the size of the implant, I would click on the green line, activate that implant. The drop-down box gives me a series of questions. I click Change Implant. The drop-down box allows me to pick a smaller diameter. I could click a smaller diameter, and it immediately appears. Then I could remeasure the site and say I like it or I don't like it. There's a rebound step where I can click back and get right back to where I was in case I lost my place. So here are 4 views of this planning of this particular patient. In the lower left, you see 3 implants well positioned in these 3 anterior teeth. If we look at the palatal view where they would emerge, the central implant looks reasonable. The other 2 look like they may not be in ideal positions. So again, we're trying to plan things in 3 dimensions. If you look at the 2 top views, this is the first placement, and then when we go to the one on the upper right, you see I was able to do what's called tilting function. I was able to tweak the implant into a better position, and now the implants are going to emerge in more ideal positions 3-dimensionally, always maintaining the implants in the bone and always thinking about where they're going to emerge in the final restoration. So our final case was completed, and you see my soft tissue augmentation done at the same time with the implant actually gave us maybe an abundant amount of soft tissue. She has a low lip line, she's happy, and we have plenty of soft tissue covering our 3 implants on the 2 centrals, and the lateral incisor on the left side. My colleague performed restorations on the canines, and you see down the bottom a post-treatment CT scan of this particular patient. Here are some higher up views of that particular restoration, and you again see on the bottom left the cross-sectional views showing that the implants were placed into our triangle of bone. We preserved the labial plate, and we were able to have in this aesthetic zone confidence that we have excellent soft tissue thickness coupled with good positioning of our implants and not needing any customization of our prosthetic abutment forms. This particular patient had an advanced periodontal condition. She's hemidentate in the maxillary arch. When she would bite into centric, all the teeth would fan out. Again, you see some of the presentations. Her particular case, we chose to do a staged approach. We extracted the teeth, performed some preservation of the sockets, and I would call that an immediate extraction with a staged approach because she went into an immediate denture, and we were not planning on doing any implant therapy at this moment in time. She actually was the patient in this particular video. She decided that she wanted to have an implant-supported restoration. We then put her into the CT scanning. We planned 6 implants for her case. You see the actual surgical template on the upper left. This was then sent to our partner who's in the laboratory aspects, and he performed a beautiful provisional restoration on the master cast. Her bone was still a little bit thin as I was placing the implants. When the bone is, not thin, our bone was quite soft when I was placing the implants. So in performing soft bone sites, I could either place the implant in an undersized restoration, meaning if I'm doing a 4.3, I would only drill to the 3.5, or I could use these prototype guided osteotomes, which we've developed to have extra length that corresponds exactly with the height and thickness of the surgical guide rings. These are available from Salva Dental, and we use that in this particular case because her bone was somewhat soft from the extraction sockets. The rest of her case proceeded as a typical guide case. We remove it. We perform some tissue punching to clean up the soft tissues and or the use of a CO2 laser, which would not interfere with the metal of the guide rings. And you see we have a well-groomed surgical site, minimally invasive. The surgery would take us about 30 to 45 minutes at most, and we have a flapless approach. Patient is very comfortable, and the case goes on very nicely. So my restorative teammate takes over, places the abutments on the provisional restoration, and this is the way she looks about 1 hour after therapy. You see the little puncture points in the vestibule. These were where the anchors were seating, and you have a screw-retained acrylic laboratory-made prosthesis on the day of the surgery. So we would call this a guided surgery or teeth in a day. Is it accurate? Well, it's accurate from two perspectives. It's accurate in where I position the implants follow the planning, but it's also accurate in the restoration is almost dead on right from the beginning. You can see some of the markers. It's very easy to adjust. And again, we do a post-operative cone beam, and you see that the implants were indeed positioned nicely. We're ready for the final restoration. This case was performed with a friend of mine and colleague, Dr. Jack Hahn in Cincinnati. These are his early markings when he first installed it. The markings are getting more in harmony. And this is the initial presentation once again, and you see her final case. She did not like her Bucky Beaver appearance. She had loose teeth, and she was able to have nice lip support. And her goal, believe it or not, was I wanted to chew a pretzel. That's all she wanted. So not only does she have beautiful aesthetics, she's happy, and she's chewing nice foods. And we have the case on the 6 implants worked out quite nicely. This is a representation of bone density or Hounsfield units of bone. Hounsfield units are density units that are used in radiology to describe the density of various anatomical structures. It originally came probably from tumor research, and we are incorporating it into our use in dental implants, looking at the various bone sites. I typically consider 3 surgical protocols. A dense protocol, I would use the drills, and I would use the tap, which is a guided tap that comes with the surgical kit for the dense bone sites. If the bone is medium, I'll just do the drilling steps. And if the bone is soft, we'll either use the compression tools or we'll use an undersized site based on the softness of the bone. So we use these, and they correspond with the gray values or the Hounsfield density. With the planning software, we can actually position implants in parallel, or we could deliberately tweak the implants into an angled position. There's a measurement tool that will tell us what angulation the implants are next to each other. You see the 2 middle implants are parallel to each other, and the measuring tool would say 0 degrees. They're exactly parallel to each other. For all-on-4 case, we could tweak it, and it works out quite nicely. Then you would use a pre-planned available abutment that comes in the software itself of 30 degrees to reorient it so all of the implants will emerge right through the occlusal aspect of the case. Here's a patient that had a class 3 occlusion. They have typically lots of bone in the area, so I had long implants, and I was able to have a nice restoration with an all-on-4 concept. Now, I have the concept for maxillary all-on-4. Do I recommend it? Not necessarily, because the bone in the upper jaw is a little bit softer. We can't get as long implants as we can in certainly like the previous case that had tremendous height, but it is a possibility to perform it as well. So when I'm doing an upper case, yes, you can do tilted implants, but I'd rather do, as we see on the right side of the screen, a series of guided implants. And if you think about how much time it takes to do the extra implants through the guide, it's a very, very minimal amount of time. So what you would add on to the cost for the patient, perhaps, is maybe they only wanted 4 implants. You could charge them for the 4 implants, charge them extra for each additional implant and the cost of the extra guide ring, but you don't necessarily have to charge them for another implant site because the guide is the same and it works out very quickly in terms of time management. There are also cases where the patients have some financial concerns, and look at this case in the middle. This is a beautiful lab-processed, all acrylic restoration. The laboratory case can last for 4 or 5 years very easily, and we could still perform a guided surgery just like we do with any of the other cases, and a restoration can be placed for the patient that should last for many years. If it breaks apart, we have acrylic restorations that can be replaced. If we have a need for an upgrade, the patient can have all the information digitally stored, and they could go to a teeth in an hour restoration if you want, without even having to do any impressions. However, I might recommend doing very standard restorations, or at least do an indexing to determine if the master cast is ideal. This is a case where we did the traditional or the original teeth in an hour restoration. My colleague on this case got a little bit carried away with the gutta-percha marks, but they beautifully demonstrate you want a number 2 round burr, gutta-percha to approximately 0.5 millimeter in depth. You want the gutta-percha in a spherical way, and you do not want any material other than gutta-percha. Try not to use stainless steel BBs or other barium markers or other material. The software knows to look for gutta-percha in the marking. The patient will wear a bite when they take the restoration. This is a PVS material. I prefer some of the denser putty materials. And like you see in the upper anteriors, you don't want it to go over the gingival aspect of the teeth, certainly, because you want to see the emergence of the soft and hard tissues in the planning software. This is the image off of the cone beam, and you see that certainly the little white dots or the markers are easily visible. The software will look for 4 markers to pair up with the template alone, and it'll easily be marked in this case. So now I'm at the planning stages. I'm able to look at, with the bone in position, I'm able to look at the restoration. In the upper left, I see the bone cross-sectional view. I see my prosthesis view. I could tilt the implant into position. The patient is then ready for the guided surgery. This is done in about 30 minutes for the patient. My teammate sits down. There's special abutments that are used for this particular process. This is a final restoration with a titanium frame and acrylic teeth and acrylic gingiva milled onto that or attached to that. Patient is inserted, occlusal marks. These are the very, very first occlusal marks as the case is seated. So I'll show you some x-rays in a minute that will show how the implants are positioned where I want, and this is showing the very nice precision of our laboratory and prosthetic work for the case. So here's the teeth restoration in position, teeth in an hour, showing the implants in position just as we planned them in our software. Here's another patient that had a full upper case. Beautiful restoration done by my laboratory, and this I show because it's a provisional restoration. If you can get your laboratory teammates to create these kinds of provisionals, we have beautiful restorations to get ideal tooth form, and as you know, we're replacing both the soft and hard tissues in the atrophy case. The other thing that's interesting about this case, if you look at the 2 central incisor implants, neither of them are loaded. The reason for that is I was not pleased with the primary stability of those implants when I placed them. So I informed my teammates that let's do the provisional restoration. We'll let those implants heal in an unloaded way, and then we're ready for the final case. We'll bring them into the restoration. So the x-ray that you see in the upper left screen is the actual provisional frame with its metal framework, and the 2 central implants are not included. This was an interesting partially edentulous case. I had bilateral considerations. On one side, I was doing what we had talked about earlier about positioning the implant next to a tooth. We also see the mental foramen in the second image, and we want to be anterior or superior to it. Here are my markings determining how close I could be to an implant or the buccal plate. Now on the other side of this particular patient, you'll see in the upper left view as well as the middle view, on the left side of the screen, a little button. Well, that was a broken implant that was previously done by some other doctors in this patient's mouth. My decision was to either leave it or I was going to trephine it out, and I wanted to see if I could straddle implants by placing them a little bit more anterior, but I didn't want to go too close to the tooth, and I wanted to have a distal implant, and that's what we were able to accomplish for this particular patient. Another partial edentulous case, funny thing about this patient is he was an examiner from the State Board of Dentistry from our community. He needed mandibular implants, so I certainly wanted to have the state-of-the-art treatment planning and restorations available for him. We wanted to have long implants, but we wanted to avoid the nerve. So in his case, we were able to create a partially edentulous surgical guide. We performed it in a flapless approach. The implants were positioned ideally. In his case, went on. I'll perhaps skip through these. These are just a few slides talking about TiUnite, which is the surface of the Nobel BioCare, which allows us the enhanced surface to get these kind of restorations performed in an immediate functional way. So just to summarize, with guided surgery, we have many advantages. Surgical colleagues would appreciate the precision and rapidity of a flapless technique. It's more comfortable for a patient, and using a surgical template, the implants are going in exactly where we place them. We see from postoperative results on the x-rays, and there are some studies performed on cadavers, that the transfer of the information is very, very precise in the magnitude of hundredths of millimeters in precision. MIS, or minimally invasive surgery, allows us the minimal surgical trauma. I find it to be tremendously cost-effective because the time to place each implant is minimized. We have one surgical template, and we could use it for several implants at the same time. The patient has the same exact number of surgical visits in the preoperative steps. If you do teeth in an hour, we are done at the final restoration. They do, in fact, have less chair time. If, on the other hand, you're doing a provisional, they would probably have the same number of chair time, but it might be less time, but maybe less or the same number of visits. The patient personally has less downtime. The results can be done highly aesthetic, as you saw from some of our restorations, even at the provisional steps, and we're able to do a lot of different steps. There's some work at Loma Linda doing brilliant work on partial edentulous cases, in particular with the aesthetic zone, and there's about 4 papers coming out from their group in the near future, and you'll see the applications of this. Originally, it came out for totally edentulous cases, which are very, very predictable. With partially edentulous and knowing how to position the implants in 3 dimensions, it's quite nice. Disadvantages are very, very minimal. If you have large grafting, well, that's required as a staged approach in most any of our treatment methodologies. Bone determinations, well, the 3D planning and the surgical guide cannot really control that. The patient presents with their available bone. In the diagnostic steps of the software, you can determine the various determinants of bone, whether they have quantity and quality. And if you have to do adjustments, well, that's just necessary in any case. The hardware or the mouth opening, you need at least 40 millimeters of bone opening. You can check the patient out. I personally have never had a problem that I couldn't get the instrumentation in. If you have a posterior case and it's a little bit long, what we do on those patients is we drill the site to depth using shorter drills. Then we install the actual length drill we're going to use into the osteotomy, then hook up the handpiece, and we save 5 to 6 millimeters that way. The need for CT, well, if you're doing high-level restorations and implant surgery, you're going to need a CT. The so-called double scan methodology is just a scan of the prosthesis, so there's no extra radiation. We have our own CT scanner in our practice, so there's no additional cost. When we were working with outside laboratories, they might charge maybe $50 extra just to do a scan of the prosthesis alone. Then the planning time is maybe up, but it's fun planning time because you're actually doing planning within software, and it almost becomes a game. Once you learn the software, it's quite reproducible, quite predictable, easy to manipulate, and a lot of fun. The chair time goes way down, especially for me as a surgical colleague, and our restorative teammates appreciate knowing in advance where their abutments are going to end up and what type of prosthesis can be planned initially. So thank you for your time. I'm going to end it here. I'm Jack Krauser for Dental XP. I hope you enjoyed this presentation and look into some of the literature reference that are available on the Dental XP. Thank you for your time.